What's up, guys? In this video, I'm going to talk to you about what you need to know to do a stroke evaluation. So first off, I always introduce myself. I talk to the patient about who I am, what I do as an occupational therapist, and just kind of give them an overview of the purpose of my visit with them and what I need to know so they can discharge to whatever facility they need to go to. And so I just kind of give them a brief overview with that, and then I go ahead and begin the assessment. I'm usually checking their vitals, I'm checking their oxygen, their blood pressure, their heart rate, getting a basic idea. And all of this is done after I've checked with the nurse. I've looked at their labs and everything to make sure that they're safe to be seen. I'm also looking to make sure that they don't have any blood pressure restrictions, because a lot of times these patients, if they had a stroke, they may have some limit, or there might be a MAP goal, which is mean arterial pressure, for what their blood pressure range should be. Sometimes doctors will say it can't go above this number or whatever. So that's something I will keep in mind, and sometimes you need to ask the nurse beforehand before seeing the patient. So for a quick stroke assessment, what I will be doing is I'm going to be testing strength. I'm just going to be doing all their manual muscle testing. I don't really test everything. I just kind of do a quick overview because some of the other tests are going to be part of my assessment. I will check fine motor and gross motor. Fine motor, I can usually test if the patient is doing enough to be able to use their hands. I will just say, can you do this? Can you touch each finger to your thumb? Then I will go ahead and just go into the test for dysdiakinesia. Did I say that right? Dysdiadokinesia, which is just testing those fast alternating movements. So I'll have them put both hands out like this. Can they do that motion? Okay. And then can you do it with the other hand? So I'm just testing to make sure that they can do that movement. If they can do that, that gives me a pretty good idea if they have any fine motor impairment. And then also when they're brushing their teeth, this kind of gives me a good idea too. So if they've already fed themselves, or if they've been able to brush their teeth, I have a good idea of what their fine motor precision is. And then I could also, have them write their name or something like that if I want to do any further testing. So that's strength, gross motor, fine motor coordination. At this point, the person is probably already sitting at the edge of the bed, and I'm checking their balance to see if they're leaning to one side, which is pretty common for anyone who had a stroke. And then I'm also checking their balance in standing. Usually I will have them, if they are safe sitting on their own, usually you say, can you cross midline, shake your hand. If they can do that, you have them stand up. That's just kind of like the normal testing methods. I don't always do that. I usually just have them stand up, and I may hold on to them. Sometimes they're leaning back, and I just kind of assess it in the moment to kind of see if this person's able to walk. If they can stand, I usually ask them to march. If they can march, sometimes I will walk with them a distance, but I usually try to check blood pressure to see if there's any major changes there. So that's strength, that's balance, and then I do an ADL assessment. Sometimes at this point, sometimes not. Sometimes I'll check vision first. It's just kind of whatever's fastest. So sometimes while I'm checking their blood pressure, I will do a vision assessment, because you can't really do anything else while you're waiting for their blood pressure to be taken. So I will just do a quick vision assessment. I will check them for any issues with saccades, with any issues with convergence, and then I will check for like a field cut. And the way I do this is I will just say, look at my finger here or my pen, and I will go in. They have that H pattern normally, but I also cross the H pattern just to kind of see if they can completely follow with their eyes. If they can follow, then I'll go on to the next step. I will have them close one of their eyes. I will ask, how many fingers am I holding? And then I'll do it on this other side. I will do it way up above them, which I'm not doing here, but I'm just kind of showing you like how many fingers am I holding. I'm doing them in different planes all around their body. And then I have them cover the other eye, do the same thing. And then I'm checking, I will say, look straight ahead at me and tell me when you see my finger. I bring my finger across from them and see if they can see it. I go up above them to see if they can see my finger, and below, and I'm just seeing if there's any hemisphere where they can't see my finger. So if they're in, this is going to see if they have any visual neglect, if they have a field cut, if they have homonymous hemiopsia. I have a hard time saying that word, but that's another thing that I would be checking. And then I will test for convergence. So I will say, look at my finger or my pen, and I go bring it to their eye and see if they can do the cross-eyed thing. That would be convergence, to see if they can do that. And that's pretty much it for my visual testing. Now, I know that's not like a full vision test. There's a lot of other things that you can do. If you have access to the motor visual perceptual test, the MVPT, that is a great resource if you want to do any further visual testing. If you notice that this person has some weird thing going on with vision, I would pull out the MVPT just to test their visual perception even further. Now, next up is sensation. This is like a neurological thing. I'll be honest with you, I don't test sensation. I know some people will like get a needle or a pen and just do like a pinprick maybe on their fingers and test like sharp and dull sensation. I don't normally do this. I would do this if it was like a hand therapy patient, but for stroke, I don't do this. And the main reason is I don't see why you would really need to do this and why it's so important. I'm sure there are some reasons. And if you have any ideas of why you should do that or any other thing that I missed in this video, please leave that in the comments below. But yeah, I don't do any major sensation testing. I will definitely check tone. And I feel like I usually do this during the manual muscle testing, right? So if I'm checking their strength, I'm also looking for their tone. I feel like it's pretty easy to see if they are like hypotonic, if they can't move the arm at all and it's just kind of flopping around and there's no tone to it. And then also if they have a ton of tone and you're moving their arm and it won't really move and it has like that rigidity to it. And then you can do the modified Ashworth scale on your documentation if you want to measure the tone. But tone, I think, is important to at least put in your documentation, but it's not something that you need to focus on for your session. You just need to see if they are hypotonic or hypertonic and include that in your documentation. Now, next up, a lot of therapists don't do this, and I think it's actually really important. This is one of the main things that I test for a stroke, even for someone who came in with a TIA, say they don't have any symptoms at all, they seem like everything is completely fine. I will do a cognitive assessment, and nobody does this. There are some OTs that do this. Usually speech covers this, but a lot of times speech isn't seeing these patients because they may not have any issue with swallowing or slurred speech or anything like that. They just came in with a TIA, so they're like PT, OT, go in and do an eval, and they don't do any speech assessment. So cognition, extremely important. I do this with a lot of my stroke patients. And I just start out by doing a simple clock test. I have them draw a clock as big as they can. I have them put all the numbers on the clock. I make sure the numbers are correct, that they're in the right place. And I ask them, I want you to put the hands on the clock. The time should be 10 past 11 because it's kind of tricking them a little bit. This is kind of like a problem-solving activity. So you're checking their vision. You're also checking for homonymous hemiopsia with their vision. And so I think this just is a great overall assessment to check not just their cognition, but their vision and their fine motor coordination. So you're checking all of that in this single, simple assessment by just having them draw a clock. So you have them draw a clock, you have them put the time 10 past 11, you make sure it's all correct. If there is any issue or if they can't do it all, this might be a big concern. They might not be able to be safe to drive. And I usually tell them if they can't do that independently and correctly, I tell them you need to follow up with your doctor before you drive. And he needs to say that you're safe to drive before you start doing so because you have some issues. It looks like there's some cognition issues. And that's something you need to follow up with your doctor about. Then what I will do is I will tell the nurse, and if I can, I will contact the doctor and say this person has cognitive deficits and they need further OT or they're going to need some sort of supervision before they go home. Because a lot of these patients, if they live alone, if they're driving, if they're doing their daily activities, I mean, this is the type of person that could start a fire in their home by leaving the stove on, or, you know, they could just have any other problem-solving issues if they are, you know, going through a yield sign or something like that. Driving is not safe for these people, so they need further assessment. So that's my big thing on cognition. So I'll do a quick clock test. It just takes like 2 to 3 minutes, right? And then if I don't have a lot of time, this is what I do. I do the clock test and then I do attention. So I give them 1 minute and I tell them you have to tell me the most words that begin with the letter F as in Frank. They have to get 11 correct. If they don't get 11 correct, there could be some cognition issue and they need further assessment. Now, if I have more time with the person, I will do further assessment, which would be like a MOCA, but I don't really do the MOCA, the Montreal Cognitive Assessment, unless I see that it is imperative. So if this is a person which they're independent with everything, like they don't have any deficits, they're passing all their cognition tests, they did fine on the clock test, they don't have any attention issues, then I'm not even going to do the MOCA in some cases. Sometimes if I have a lot of time, I will, but I usually use the MOCA for people that are more involved, that are having more deficits. I think the MOCA is a great tool for anyone that has difficulty problem solving, or anyone who has difficulty like with sustained attention, or maybe problems with sequencing. I think that's when the MOCA can be really helpful. But for everything else, I just do the clock tests. I do an attention test with those words beginning with the letter F. And then I'll just do orientation questions. So where are you? What's today's date? Why are you here? Okay, so that is pretty much my basic stroke assessment. I will obviously do ADLs as well. I'll usually make sure they can get dressed on their own. Can they put socks on? That's usually the hard one. I will see if how their balance is, transferring to the bathroom, to the toilet. It's mainly just seeing, can they do socks? Can they transfer to the toilet? Can they brush their teeth at the sink? Because that's where I'm checking coordination, balance, and the ability to be able to do their ADLs and function as they normally would. Because if they can do socks, they can pretty much do pants. And so it just kind of gives me a rough idea if they can do their basic daily activities at home. So that's pretty much it, guys. That is all of it in a short amount of time. You can really do a lot of things. And then I do the education. So that's kind of the last piece. And the big thing is always talking about BFAST, educating the person on the stroke signs and symptoms. BFAST is just going to be reminding them that if you had a stroke, you could have problems with balance, eyes, face. F is for face, facial droop. A is for arms if they have weakness in one arm. S is for speech. And then if you have any of those symptoms, T is for time. You call 911 to get to the hospital as soon as possible. So I go over BFAST relatively quickly. At our facility, we hand out a stroke pamphlet that gives them all the information on BFAST and other information to prevent strokes in the future, or TIA, so they can get to the hospital as soon as possible, so they can get whatever they need, if that's TPA or whatever the doctor may prescribe for them. So I go over BFAST. If the person has weakness on one arm, I will start right away on educating the patient and the caregiver on activities to use that upper extremity. So if they have weakness on, let's say, the left arm, I'll say start using that arm as much as possible. I will educate them on wrists. If they have the motion to be able to do the wrist pumps, fist pumps. I'll have them touch their finger to the thumb if they can, and then I'll do elbow if they can do that, and I'll do like shoulder range of motion. But shoulder you want to be extra careful with, because if they have a subluxation in their shoulder, it could just be an issue. If the family member is going to be doing the range of motion for the shoulder, I'll teach them up to like a certain level, like 90 degrees or something, and I won't really go much higher than that. So I'll usually just go over range of motion. I'll go over self range of motion for the patient so they can do range of motion on their own. And then another thing I do is I'll go over neuromuscular reeducation. And the main thing I do with this is you can do the D1, D2 patterns. I mean, if you want to go over that, I usually do that in like my second treatment. But the main thing that I do talking with the patient and the family member is I go over weight bearing and the importance of weight bearing on that limb, especially the upper extremity, because a lot of times they don't get that back. And it's just, if they're in a wheelchair, it's leaning on that arm. If they're sitting at the edge of the bed, it's putting pressure through that limb and leaning on it. And I think that's just really helpful for the family and the patient, so they can go ahead and get started on doing that re-education to hopefully help them over time. And then I normally just ask the family if they have any questions, and I go over equipment, any equipment that they might need if they're going to be going home, which is going to be, it could be a bedside commode, it could be a shower chair, or whatever. I feel like most of you probably have a good idea of what equipment they already need. And then I just go over a quick assessment with what their living situation was. I usually do this before my evaluation. I go over their prior level of functioning, if they had any issues before, if they had any residual weakness from a previous stroke and all that. I'm asking all those questions about their home environment. Do they have a walk-in shower, tub shower? Is it a single level home or two-story home? That's all in kind of like the initial assessment. But those are just kind of the main pieces that I go over in my stroke assessment, just to kind of give you a better idea. There's a lot to a stroke. There's a lot of things that you can include. I'm sure I didn't include everything in this video. So if you have anything to add to this, please leave it in the comments below. And I hope you enjoyed this video. Please like, subscribe. I will see you in the next one. I hope you have a great day.